the next hour or so, we're going to change our format. Rather than having a presentation, we're going to take pretty much every question we've been asked, whether it by social media, by email, or support group contacts, and we're going to invite Dr. Nick Hirani and Professor Simon Hart to answer as many as we can get through. Now, Nick isn't quite here yet, but I'll introduce him anyway. He is a consultant respiratory physician at the Royal Infirmary in Edinburgh and a principal investigator at the Centre for Inflammation Research. Simon, who we've seen before, and you've seen him do a very good presentation a year ago at this patient day. He's professor in respiratory medicine at Hull York Medical School and a consultant at Hull University Teaching Hospital. He's been a great friend of the charity for many years. Now, both Nick and Simon are members of our medical and scientific advisory panel. We are very grateful for the time you give to us. Nick, would you like to start solo and for Nick to join in due course? Sorry, Simon even. Would you
Yeah,
like to join solo?
absolutely fine, Graham. Happy to kick off.
Okay, well, we've got just over the hour, and you've obviously seen some questions in advance, and we've had some more arrive today in our Q&A. So we'll have a look at the Q&A ones later on today. So if you, in the audience today, if you have a question that you feel is worthy of being asked, please do so. But the only caveat being, please avoid being personally identifiable or anything which is personally clinical related to your treatment, so we don't breach any confidentialities there. Um, well, Simon, we have pages of questions, as you know. So I will start off by this first one too, and we'll see where that goes. Um, a patient is reporting joint pain, swollen eyes, dark patches on their skin, and breathing difficulties. Could all of these symptoms be related to sarcoidosis?
Well, Graham, I think most of the audience were probably here for Professor Rabina Coker's talk earlier, which I caught the second half of, which was really excellent. And one of the things that Rabina emphasized was the importance of looking broadly as a clinician for the cause of the patient's symptoms. So even if you're a patient who's been diagnosed with sarcoidosis, that doesn't mean necessarily that all of your symptoms are due to sarcoidosis or that any new symptoms that develop are directly related. So we as clinicians should always be looking very carefully and keeping an open mind. So whilst the symptoms reported in the question, joint pain, swollen eyes, dark patches on the skin, breathing difficulties, could be symptoms of sarcoidosis, there are other conditions that could cause a similar constellation of symptoms as well. So it's very important in that situation, if those symptoms are persistent, that they are looked at carefully and the appropriate investigations are done. And if they are due to sarcoidosis, that should be fairly straightforward to diagnose that in the usual ways, using some of the investigations that Professor Coker was talking about earlier.
Okay, and now I think Professor Coker did a very, very good analysis of the various types of medication that's available. But the question we've had next is about mycophenolate. And is it safe to take it permanently? The patient is currently taking 1 gram twice daily to treat sarcoidosis in the lungs, liver, heart, lymph nodes, and lacrimal glands. So clearly a fairly major impact there of sarcoidosis.
Yeah. Thanks, Graham. So yeah, this is a question about the drug called mycophenolate, which was one of those immunosuppressants that Professor Coker was listing, which are sometimes used long-term to treat sarcoidosis. So these are a group of drugs that are not steroids. So the idea is that if you take one of these drugs, you are not going to be afflicted by steroid-related side effects in the long term. But as she mentioned, they come with their own potential problems as well, but they are sometimes used to treat sarcoidosis. And the questioner wants to know, is it safe to take it permanently? Well, the side effects of drugs like mycophenolate and similar drugs are infection. So there's always a risk of infection, which occasionally can be serious infection. And that's because these drugs deliberately suppress the immune system. That's what they're designed to do. And as we'll come on, we've got quite a few questions about immunosuppression in the that have been submitted. So we'll talk a little bit more about that a bit later on. But these drugs were basically developed for transplant recipients. So they were developed to reduce the risk or prevent the risk of organ rejection in a patient who's received an organ transplant for whatever reason, a new kidney, a new lung. And they've been extended to be used to treat conditions in which the immune system is overactive, autoimmune diseases, and disease like sarcoidosis. So infection is the main risk there is, and anyone who takes mycophenolate should be aware of this, a small increased risk of cancer if you take these drugs long term. And that's because the immune system is not just important for protecting us against infection, but it also protects us against the development of cancer. And the particular cancers we're looking for is skin. So anyone who takes any of these drugs long term should be cautious about looking for any changes in the skin. We know, of course, that skin cancer is largely driven by ultraviolet light. So you'd want to take sensible avoidance measures against strong UV light. In other words, put on plenty of sunblock when it's sunny, and keep an eye on the skin. These are the recognized long-term risks of these drugs. But if the benefit of the drug outweighs the risk, then that's why the patient will be continuing to take it.
Well, actually, on that point about the benefits of the drug, there's a question just come in actually an hour or so. If I could just maybe raise that now. It's about prednisolone rather than mycophenolate. But the questioner asks, taking prednisolone left me with adrenal insufficiency. Well, A, is that common? And is there any advice on how that can be improved?
Yeah. Thanks, Graham. So prednisolone is steroid, and again, Professor Coker talked about some of the potential issues with long-term steroid treatment with prednisolone. So we all need a bit of steroid, and that's produced by our adrenal glands. And so if you take steroid tablets in the long term, your own adrenal glands will decide that they don't need to make any steroid anymore. The natural steroid they produce is called cortisol. They don't need to produce that anymore, and they will go to sleep, basically, which means that if you were to suddenly stop the prednisolone, you won't produce enough cortisol from your adrenal glands because they'll be hibernating, if you like. And that's why people on long-term steroid therapy carry a card which says you should not stop your treatment very quickly. And so the questioner is about the adrenal glands not working because of long-term steroid therapy. So the way to manage that, and if the aim is to get off steroid therapy and taper it away to zero, is to use as low a dose as possible, to reduce the dose very, very slowly, which may be at 1 milligram at a time every few weeks, for example. And if there have been previous problems with the adrenal gland not kicking back in when they need to, as a response to that, then there are ways of testing that with what's called a synaptin test, and ways of trying to deal with that by switching the prednisolone to a different steroid, hydrocortisone, and bringing the dose down even more gently. So it's not usually a long-term problem, but it sometimes can be.
Okay, thank you. A total change of tack now to a symptom that I think pretty much every sarcoidosis patient experiences: fatigue. And I know we've spoken about fatigue at recent patient days in the past, but the question here is, what is the best advice for somebody who is suffering from fatigue? And the supplementary question to go with it then is, obviously exercise is good, and I think Professor Coker was very clear that exercise will definitely improve lung issues. But if a person has big issues with fatigue, then exercise becomes a big problem. What would you recommend to increase energy?
Sorry, Graham, my computer's decided to try and hibernate there itself. So I think we're back online, so that's fine.
It's the
Yeah.
Zoom day today, it really is.
Yeah, it's good. Fatigue is challenging. It's a difficult symptom to live with. As Professor Coker was saying, there were millions of pounds of research money spent on looking at the fatigue associated with long COVID. And but unfortunately, I don't think we've really got any clearer answers as a result of that. The fatigue of sarcoid is almost identical in terms of its symptoms to the fatigue of long COVID, the fatigue in chronic fatigue syndrome, the fatigue that other patients with other inflammatory diseases suffer from, like multiple sclerosis or other autoimmune disease. And it's very challenging in all of these conditions, and we don't really have a great treatment for it. So I think that the resource that's on the Sarcoidosis UK website about fatigue is fantastic, and there are various links there to further information. Yes, the problem with exercise, as people who suffer from fatigue, of course, well know, is that exercise is good, but if you overdo it, then the next day you can feel completely wiped out and unable to function. So it's a question of tailoring the exercise and adjusting it to just the right amount, not too little, but not too much. But I would refer to the resources on the Sarcoidosis UK website.
Okay.
Drug treatment for fatigue that Professor Coker mentioned is generally unrewarding. It usually doesn't work, and the side effects of the drugs are often worse than the underlying problem.
Okay. In fact, I'm looking out of the window now at the weather there, and we have a weather question come in. So I'm not asking you to forecast the weather, but the question that's been asked is, I find any change in the weather, especially if it changes for the worse, has a big effect on how I feel. Is that typical? Is that a sarcoidosis issue? Or is that just a way of life for us all question?
Yeah, I think it's a more general issue related to folk with inflammatory problems. You know, people who are troubled by osteoarthritis, joint problems will very clear that changes in the weather, changes in the atmospheric pressure and the temperature have a big effect on their joint symptoms, for example. So, you know, there are some of my patients who are lucky enough to be able to spend the winter months abroad, somewhere a bit warmer, the Canaries or the south of Spain, and that's fantastic. It'd be great if we could prescribe a 3-month holiday in the sun for everybody over the winter. But yes, there's, you know, living in this part of the world, unfortunately, we just have to deal with that.
Mm. It's a shame you can't prescribe that, Simon. I think we'd all be at your door in that case.
Yeah.
I think NICE may have something to say. But again, one of the comments that I think that Professor Coker said was about terminology. And we always use words. And I think very often we use the word without necessarily knowing what it necessarily means. And we hear about immunosuppression or
Yeah.
being immunosuppressed. But what in layman's terms does that actually mean?
Yeah. So a good definition, I think, would be partial or complete suppression of the immune response. So our immune system is here to protect us against infection. It's evolved that way. And if that is partially or completely impaired, then that's immunosuppression. Now, that may occur for a variety of reasons. So it may occur naturally due to a disease, which may be congenital, that is inherited. So there are rare inherited immunodeficiencies that affect children because some parts of the immune system don't develop properly. Or it could be acquired due to a disease that suppresses the immune system. Classic example would be infection with HIV virus, the cause of AIDS, acquired immune deficiency syndrome. Or immunosuppression is artificially induced deliberately, either for a transplant organ recipient to suppress the normal immune response that would tend to reject that organ. As we've said, most of our knowledge and understanding about ways the immune system works and drugs used to affect it have actually come from studies of transplantation. Or artificially induced for the treatment of an autoimmune disease or a disease like sarcoid, where the immune system becomes overactive. Usually with drugs to suppress the immune system, but actually, radiation therapy, removing someone's spleen, or other methods can sometimes be used to suppress the immune system. For example, in hematology patients, for example.
Thank you. Now, earlier this month, our social media pages were absolutely full of concerns over the COVID autumn booster and why, for the last 3 booster cycles, sarcoidosis patients qualified, and this time they do not qualify because of the changes in guidance. The question that many people have asked is the risk actually less? And we'll avoid the politics perhaps, but
Yeah.
what is the advice to people?
Yeah. So, this has caused lots of consternation, not just amongst patients with sarcoidosis, but amongst patients with various other diseases that previously were labeled clinically vulnerable and hence were eligible for COVID vaccination during the pandemic, after the vaccines were first developed in 2021 and for a few years after that. The government's position, or the position, is guided by a committee called the Joint Committee on Vaccination and Immunisation that advises the government on their vaccination campaigns. And I've always been extremely impressed by the JCVI, and their guidance always seems to be balanced, based on science, based on evidence, and well-reasoned. And actually, I think it is again this time as well. I think the problem has just been communication and a lack of explanation as to why the previously clinically vulnerable groups are now no longer eligible for this next round of vaccination, because the groups in the currently recommended are over 75 or immunosuppressed, basically. So if you have a condition like sarcoid, but you're not immunosuppressed and you're not over 75, then you're no longer eligible. Now, actually, the JCVI webpage explains it actually quite nicely. It's a bit scientific, but it does actually explain their rationale. And the rationale is that if you have been previously vaccinated against COVID, as we all would have been or should have been, then contracting COVID nowadays is not a serious disease like it used to be. And the vaccination program is all about preventing people from becoming either seriously unwell or dying. And given that COVID in a previously vaccinated person, if he had a few vaccines before, as advised, is no longer a serious disease, and I think many of us or most of us would have experienced that. I don't know about others, but in the last few years, I think many of us will have had COVID, and it had been a nasty, a kind of flu-like illness, but not serious enough for us to be admitted to hospital. Because of that, the vaccination program is targeted at those at highest risk of becoming seriously unwell or dying, and older age is by far the strongest risk factor for that, hence the over 75s. And people who are immunosuppressed, as we've just discussed, the reasons why that might be, don't mount a good immune response against the vaccine. That vaccine is designed such that the immune system then remembers that COVID and then can react against it again. Obviously, if the immune system's suppressed, that doesn't work quite as well. And hence, those people who are immunosuppressed are also eligible for a further vaccination. But if you're not in either of those groups and you've been previously vaccinated as advised, then your risk of being seriously unwell or dying from COVID is so extremely small that's why you're no longer recommended. And I think that's, if you do dabble in their web page, even though it's a bit scientific, they do explain this, but it's obviously not been communicated quite as well as it should.
Yeah, thank you. I think the confusion was around the original June press release and the Green Book not actually matching each other, but I can see that has been changed now. So again, I hope that reassures people. Let's go back into the safe world of medication then. And A patient with a combination of pred and mycophenolate has had the best quality of life since diagnosis and has minimal side effects, but he or her consultant and GPs want to reduce the pred. Why would they want to do it? And
Yeah.
is there an alternative medication?
Yeah. So, um, as we've heard, long-term treatment with steroid or an immunosuppressant, or in combination, as is commonly used, has potential downsides and potential risks. And so it is reasonable, if the sarcoidosis is controlled, at some stage to try to bring the dose down. And again, Professor Coker described this in her talk, that maybe, some patients are going to need lifelong treatment, but some patients might only need treatment for 3 to 5 years, for example, whilst the natural history of sarcoidosis takes its course, which in those patients often is for it to settle down so that the treatment can be reduced or be withdrawn. The trick is then, the important thing is that whilst that is happening, that there is a medication reduction, that there is close monitoring of the factors that Ravina talked about, symptoms, imaging, CT or X-ray, or lung function if it's pulmonary sarcoid, but appropriate tests of other organs if those are affected, and that those are closely monitored as the dose is reduced or stopped to look for any worsening of the disease. And if that can be done in a supervised, careful way, then that's what I would recommend as well.
So that would take you to sort of maintenance dose then, would that effectively?
Say again, sorry?
Would that take you to sort of a maintenance dose of the drug then, or would you try to get rid of it completely?
Well, if a patient's on both drugs, steroid plus mycophenolate, the ideal situation would be to take the steroid away and to use mycophenolate alone in the long term, because that's its idea, that it's what they call a steroid sparing agent. And therefore, the patient is spared the potential of serious long-term problems related to steroid therapy, including thinning of the bones, for example. So if you're going to use one agent alone, then that's the argument for trying to taper and reduce the prednisolone. And we might get on to questions about clinical trials of new agents, but those have shown us that many patients who are on long-term steroid therapy for sarcoidosis could quite happily be managed on much lower or even no steroid at all.
Right. And how often would you recommend medication being reviewed?
Well, as Ravina explained very nicely, if a decision is made for some longish term treatment, 3 to 5 years or so, then at that point, but some patients might need only treatment for a few months or even 12 months, for example. So I think it depends on the severity and the extent of the sarcoidosis, but there's always an argument every time to think about, every time the patient comes for a clinic review, to think, is this much treatment needed? Could we try to reduce it whilst carefully monitoring to make sure that the sarcoidosis remains controlled? And again, that's a decision that's made in conjunction with you as the patient. That very much is that negotiation, that deal, if you like, about the trade-offs, the benefits against the downsides.
Okay, thank you. Nick, welcome.
Hello. Sorry, I'm hopeful that you've answered all the difficult questions, Simon.
We all saved those for you. So we every second one we've saved for you, because we know you've got better weather than us as well up there. So we feel you need
remarkably, yeah. Apologies, sincere apologies to all of you attending. Sorry.
Anyway, welcoming Nick to join us. Thank you. I'll ask Nick the first question then now. So we'll cut into blood tests. And how does an ACE blood test work? Is it reliable? Can a GP request one, or is it only available through a consultant?
Yeah. So serum ACE, angiotensin converting enzyme. It's an enzyme that's made by the granulomas, which are actually part and parcel of sarcoidosis. And but it's not specific to sarcoidosis. That's the unfortunate thing. So there are lots of diseases that sometimes look similar to sarcoidosis, very disappointingly, that actually cause an increase in ACE levels. It does correlate with the activity of the disease, like sarcoidosis, but you can't be diagnostic of sarcoidosis. So, for example, TB has ACE levels, hypersensitive pneumonitis, silicosis, lots of conditions actually very similar sometimes to present to sarcoidosis. So, but if you do have sarcoidosis and your serum ACE is raised, I think we're all agreed that that is a sign that you've got some activity. The sarcoid granulomas are active, and you can monitor the serum ACE if you do have it raised at presentation as a kind of marker of activity and a marker of response. It's not infallible. And a lot of people, not a lot of people, but actually, I think about 20% of patients in my experience don't have any serum ACE raised, even if they have sarcoidosis. So it's not, you can have active sarcoidosis without having an ACE level. But if it's raised, then we tend to use it as a part of a biomarker and a part of a panel of other markers that we use for disease activity. That might be the chest X-ray or other clinical features. It might be the calcium level. It shouldn't be used in isolation. So if your serum ACE goes up and the patient's feeling completely well and there's no other features of sarcoidosis, I wouldn't use that as a reason to say to increase the treatment, for example.
Okay. Right. Now, earlier I was talking about GPs and the fact that GPs have to do an awful lot of things and have to be really, really jacks of all trade here and won't know about every disease that comes along. But we do know that training is improving. But we also know that in most GP practices, a typical GP will see maybe one sarcoidosis patient in their whole career, which makes life tricky. Now, the question that's being asked is, how would you explain sarcoidosis to a GP? In this scenario here, the patient doesn't have a named GP, has a medical history stuffed full of sarcoidosis, but whenever they go to the GP, they will see whoever's available that day, or a locum, or whoever else, which then leads to an awful lot of wasted or repeated referrals to the wrong people. How should this patient explain what he or she needs? Actually, it's a she. What she actually needs to get the best from a GP appointment without wasting that precious 10 minutes?
Yeah,
You
well,
got an hour on that one, Nick.
that's $1 million question. I'm really hopeful that Simon would have answered that before, actually. Yeah. So how to not waste a GP's time in 10 minutes? That's a difficult one. So I often say to patients who don't know about sarcoidosis, I describe it as an immune condition. Now, an immune condition is kind of a broad term that something's going wrong with the immune system. It's triggered by an unknown cause, but your body is reacting to something and forming these disease-associated granulomas. And the granulomas can cause inflammation and fibrosis that can affect various organs. And the commonest organs are skin, eye, lung. So I think you could explain, if you GPs will all know about sarcoidosis, but they probably won't remember in detail what they've learned at medical school. So I would explain it as an immune kind of reaction, and then focus in on what exactly the symptoms are that patient is experiencing and what the sarcoidosis target organs are. So that's different for every patient, but it might be skin, it might be fatigue, it might be lung. And that way, the GP, even if they don't know much about sarcoidosis or they're not expert in sarcoidosis, they can refer the patient to the right kind of specialty. Most hospitals, as you probably know, and including my hospital, doesn't have a dedicated sarcoid expert that cross-cuts all the organs. So neurosarcoidosis presents to the neurologist, who are pretty good and expert at their field, they don't see very much sarcoidosis, but they have experts on neurosarcoidosis, and same with me for lung, and same with me same for the dermatologist. So very few hospitals have a guru for sarcoidosis that can know about all the different organs. So the GP really is the job is to direct the patient to the specialty that is most involved in that organ.
Okay. I think it's very hard for anybody in that situation, in fact. Next question is probably a relatively, or fortunately, a relatively rare question. And it's in two parts, so maybe you do half each, or you can pay your price, Nick. I don't know. So, what is your experience of patients who do not go into remission? They've always got the symptoms, but continue to have flare-ups even with the maximum treatment they can have, and what is causing that? And maybe a supplementary, what can they expect for further experience?
Okay, so I think that's a question that actually is dependent on different clinicians. So maybe I'll have a go, and then maybe Simon will have a go, because there is no guidelines that that have a uniform um, uh, therapeutic response for that. You know, there's no guidelines that say actually you must do this or that, basically. So the question is remission, so exacerbation. So the patient is in remission, but they have frequent exacerbations. So the question is really, what form are the exacerbations in? You know, so what organ is being involved, and what form of the exacerbations, and is it a real exacerbation, or is it, for example, a common manifestation is the patient is on treatment, but they're adjusting the treatment, for example, lowering the steroids, and they have a manifestation that they might think it's sarcoidosis, and the clinician might think it's sarcoidosis, but it might be a manifestation of reducing the steroids and just the effect of reducing steroids, not necessarily sarcoidosis, but the body's response to reducing steroids, because the adrenal glands, your own body has to release more steroids of its own, and that there's a bit of catch up for that. So fatigue, for example, is quite common in sarcoidosis. It's quite common when we reduce the steroids, patients feel they're more fatigued. It's very difficult to ascertain whether that fatigue is because the steroids are being reduced or it's a flare-up of sarcoidosis. And that's why you need different markers of disease activity to know. If it is a genuine flare-up, then the most common remedies for that are what the remedies are that you first started off when you had your first flare-up. So if steroids worked for your first flare-up, they'll work with flare-ups subsequently. But now the advantage of that is that the subsequent flare-ups, you know what dose to use first. You might know how long the patient will take to respond because you have some experience of a previous episode. And then you've got steroid-sparing agents, of which you might have discussed already, but there are several: azathioprine, methotrexate, mycophenolate, and you think you might have discussed that with Simon. But maybe Simon has some other ideas as well.
No, I agree with that, Nick. Related to what we said before, it's important to have a good assessment by an experienced clinician, isn't it, to try to work out whether the worsening symptoms are due to the sarcoid, due to treatment or treatment changes, as you quite correctly say, something else happening, an intercurrent infection. If a patient, these granulomas that form sarcoidosis, they take weeks to form and weeks to reduce. So if someone's got symptoms that are changing very rapidly, suddenly appeared, it's less likely that that's directly related to the sarcoidosis. And in my initial approach would be to think, well, there must be something else going on here. So again, as we've touched on before, Graham, very important to keep an open mind and do a comprehensive assessment in this sort of situation.
Well, let us move on to vitamin D, which seems to be a subject which divides many people, including dietitians. So advice around vitamin D seems conflicting. Dietitians recommend it, but many sarcoidosis consultants warn against too much of it for their patients. Who is correct, and what is the risk?
can you choose who you want to answer this? Because
I'm just going to sit here and let you decide.
well, I
You
should
started,
probably
Nick,
answer
so
first because Simon's done 15 minutes of work before me, and then so it is controversial, vitamin D, and everybody starts with, oh, vitamin D is very complex. The metabolism in the body is complex, and it's true, actually, it's complex. So briefly, what we measure in the blood routinely is what we call the storage form or inactive form of vitamin D. That's what most GPs measure, most labs measure, and actually that's the standard measure. Okay, and then there's an active form of vitamin D, which the body converts from the inactive form, and that form of vitamin D is difficult to measure. That's called the 125 vitamin D, and it's difficult to measure. Biochemically, it's difficult to measure. It needs a very short window when the blood sample's been taken to the lab, and it's actually a lot of labs don't do it. So it's the inactive form of vitamin D that we measure. So a lot of patients with sarcoidosis and a lot of patients in the general population have lowish levels of vitamin D. That's kind of common in the UK to have a lowish level of vitamin D. Sarcoidosis have more increased proportion of patients have low vitamin D than non-sarcoidosis patients. So that's true. It's a question of really what you do about this low vitamin D, because the danger of supplementing vitamin D is that the sarcoidosis actually has the granulomas form active vitamin D on their own. So you can have a low inactive form, the measured form, and have a high active form that you can't measure. And the high active form can lead to a serious complication called hypercalcemia, high calcium level. So if you have a very low inactive form that you measure, and you don't measure the active form, which is difficult to measure, and you have a normal calcium level, then if you supplement the patient to vitamin D, especially if you supplement to high doses of vitamin D, you risk hypercalcemia. You risk this complication, and sometimes it's a very serious complication. Sometimes, and most patients don't experience that. Of course, most patients with sarcoidosis don't experience that, but it does have a serious implication if you do have high calcium if it's untreated. So the bottom line is that vitamin D levels, I think, should be measured in patients with sarcoidosis, the inactive form. And most GPs and most clinicians measure them, though I don't think the guidelines say that every patient should have it measured, but I tend to measure vitamin D in patients with sarcoidosis. I only treat vitamin D levels if they're very low. Now, that might be controversial, and other people have different opinions because, as you say, there's complicated and no definite guidelines. But they're very low. For me, very low. A sort of normal level is, I think, about above 50, and very low is below 20 or 25, and a borderline low is between 25 and 50. So it's very low vitamin D levels. I tend to treat the patient, especially if they have any symptoms. But the symptoms of very low vitamin D and the symptoms of sarcoidosis sometimes overlap. Fatigue actually is very common. So I would cautiously supplement a very low vitamin D level if the calcium level is normal with a low dose of vitamin D. And the low dose, I think, probably 400 international units, which is quite a low dose. It's actually recommended dose actually for normal people, but I can see supplements over the counter. I've seen supplements over the counter that have 800, 1,200 international units of vitamin D daily use. That's too high for patients with sarcoidosis. And in the borderline low and the normal vitamin D levels, I wouldn't suggest any supplementation. I just suggest plenty of sunlight if you can and a healthy diet. I'd be interested in what Simon says about this as well.
No, thanks, Nick. That was very nicely explained. I think my impression is that, and of course, the reason that people are worried about vitamin D and want to supplement vitamin D is it's important for bone health. healthy bones need vitamin D, and it's not present in our diet to any extent. It's produced in the skin normally in response to sunlight, which we're a bit lacking in this part of the world, especially at this time of year. I think most of the people I've seen who run into problem with high calcium levels with vitamin D are patients who've had a problem with high calcium levels in the past. So if you're a patient with sarcoidosis and you've had high calcium levels, and that will be measured on a blood test with your sarcoidosis before, then you've probably got to be a lot more cautious with taking vitamin D than somebody who hasn't. Occasionally it can develop, I think, in people who've not had high calcium levels before. So it's prudent to monitor the calcium level, which can be measured in a blood test. And I suppose the only different situation, I suppose, Nick, and I'd be interested to hear your thoughts about this, are patients on steroid therapy. Where bone health is even more important because steroids can thin the bones, and they're probably more of an argument to give vitamin D supplementation to someone who's on steroid therapy. And I think that's probably okay, because in my experience, even low dose steroid therapy is very good at suppressing the high calcium levels in the blood in people with sarcoidosis, so that it's less likely to be a problem. Would that be the same as your practice?
I would agree with you completely, Simon, that patients with steroid therapy, vitamin D supplementation to improve bone health is absolutely fine, I think. Supplemental calcium, I don't think is necessary, and probably, I don't think it's recommended. And then, I only know this because, I have the luxury of a bone expert quite close to me, and that bisphosphonates are reasonable and they're safe in sarcoidosis as well and improve bone health. So vitamin D and bisphosphonates are fine, but supplemental calcium is probably not fine in sarcoidosis. And I think that's probably the general consensus.
Thank you. So I guess the vitamin D aspect of sunshine, the advice is, as ever, high factor sun cream and don't get too much of it. But we know also that sunny break can be good for patients as well. Okay, let's go into a nice safe area of steroids then now, which is non-contentious, I'm sure. How common is it to develop diabetes after a course of steroids? And is there any way to avoid this or reduce the risk?
Simon, do you want to go for this first? And then I can't remember what we've decided.
So I was lucky, Nick, I was lucky enough to catch the end of, or the second half of Rubina Coker's talk this morning, and she did a comprehensive talk about all aspects of sarcoidosis, including touched on issues with various therapies. So that was very helpful groundwork. But so Rubina did, and we've talked about this before, that the issues with some potential issues or problems or hazards with steroid therapy. And one of them is the development of diabetes. Now, what steroids probably do in terms of causing diabetes is that they bring out diabetes in people who are prone to diabetes, or if they haven't had steroid therapy, might develop diabetes by themselves 5 or 10 years down the line. So they're kind of at risk of developing diabetes. Type 2 diabetes is what we're talking about here. And because steroids have the opposite effect to the hormone insulin, which is the one that's lacking in diabetes, steroid therapy can bring out diabetes. So that's something that, if I'm offering steroid therapy or discussing steroid therapy with a patient with sarcoidosis, something that I'll always discuss and say that, well, if we're starting steroid therapy, you do need to watch out for symptoms of diabetes, which might be passing lots of urine, getting up at night to pass urine, or feeling very thirsty. And it can be tested for with a blood test or a urine test. So the risk cannot be removed. It's probably dose related. So the higher dose of steroid that you take, the higher the risk. Again, an argument to use as low dose as possible, as we've talked about before. And there are some patients in whom it's going to be more of a risk, and those patients who are at risk of diabetes because they either have weight issues or they've got a family history of diabetes, for example. So we need to be aware of it and monitor.
Just a recent thing that I've learnt because I'm no diabetologist, but this diagnosis of pre-diabetes, which you've hinted at, which is a risk factors for diabetes. So our diabetologists recommend doing a blood test, the glycosylated hemoglobin, before you start steroids to assess the risk of subsequently having precipitating diabetes in a patient that doesn't have diabetes, that has this kind of blood test that has a glycosylated hemoglobin is basically a test, a blood test, a simple blood test. The GPs can do it routinely, and it tells you how long your blood glucose has been above the normal range for. It gives you an outline of really how chronic raised glucose has been in the blood in the last few months, effectively. And I'd probably think that's probably a good idea to assess the risk of diabetes before. It wouldn't deter me to use steroids if I needed to use steroids for sarcoidosis, but you could say to the patient, you're much more likely to get diabetes, frank diabetes, if you have this glycosylated hemoglobin that's high, and maybe that's more cautious use of basically monitoring the glucose subsequently.
Okay, thank you. And a follow-up to steroids in general, we often hear people concerned that sweating is a side effect of steroids. And is it common? Why does it happen? And is there anything a patient can do to reduce the impact of it?
So I've heard this from some patients, but I have actually heard this as a symptom for a lot of patients that don't have sarcoidosis or are not on steroids, and I have heard it for patients that are on sarcoidosis that don't have steroids as well. So I'm pretty sure it's listed in the side effects. And if a patient tells me they didn't sweat before and they have now started steroids and they sweat a lot, I assume that's a side effect of steroids. It's relatively uncommon, and I would think about other causes of sweats, drenching sweat. The patient of the age where the menopausal symptoms, for example, or other causes. But it's unfortunately one of these side effects that are very difficult to harness and treat, and it's very peculiar. And I don't know what the mechanism is, if it is a steroid side effect, what the mechanism is to correct it.
Yeah, I think you're right, Nick. I think our colleagues who run the endocrine clinics see quite a lot of patients who have sweating problems for reasons that aren't exactly clear. The solution, again, Graham, is use as low a dose as possible.
Okay, well, here's an interesting one for you. And obviously, there's a connection between a GP and the consultant in hospitals. We regularly now hear of patients who are seen by a hospital consultant, recommended a medication, their GPs then are unable to or refuse to prescribe. One of the scenarios that I've come across recently is a patient who is being treated well out of area, but has to go back to that hospital every 28 days to collect the packet of pills that consultant has prescribed, but their GP either can't or won't. Is this common, and is there any way it can be resolved? Because clearly driving 2 or 3 hours to go and pick a pills up seems to be pretty poor.
Shall I give the English perspective, and then Nick can give tell us how the fantastic health system in Scotland deals with this. So again, I think Robina hinted at this, and so we're talking about the non-steroid immunosuppressant drugs like methotrexate and azathioprine and mycophenolate. They are listed in England anyway as what's called an amber drug. They're on what's called an amber list. It's a traffic light related list. And that means that these are drugs that need to be initiated by a specialist in hospital, but the continued prescribing and monitoring can be handed over to primary care, to general practice, with in place what's called a shared care agreement that is signed by me as the specialist and by the GP who's taking it over, which includes all aspects of what needs to be done in terms of the safe monitoring of that treatment, how often the blood tests have to be done, what to do if they're abnormal, etc., etc. And in recent years, it's become more difficult, and I think that's probably what the questioner is hinting at, is that many GPs are basically being told that they're not commissioned or paid to provide this service, and therefore they will no longer do it. And that's why the patient then has to have their blood tests still at the hospital and the prescription still issued by the hospital. And that has become, it seems to be getting more and more common. How about north of the border, Nick?
Well, I'd like to claim that it's a better better service, but it's exactly the same. It's a shared care protocol. It's the same system, and GPs are increasingly pressured to not adopt a shared care protocol for the newer drugs, but for the drugs that we've already been using commonly, methotrexate and azathioprine, we do have shared care protocols, and the patient shouldn't have to collect their prescription every 3 months, or sooner from the hospital rather than the GP if they have a shared care protocol. But for newer drugs, there will be some resistance, and the resistance is just motivated by the actual pressures the GP feels rather than anything more egregious than that.
Okay, let's stick with immunosuppressants then. And I think Professor Coker gave a very, very good summary of the various medications that are out there earlier, but what are the long-term impacts of immunosuppressants, and are biologics proving to be a better option for those with long-term symptoms? And maybe you could just explain what biologics are as well, because I think it will be new to some people.
Okay, so the biologic drugs refers basically to drugs that are antibodies. So they are antibodies, of course, what are one of the things that our immune system produces to protect us against infection. But antibodies have been developed as drugs because they are very good at targeting down, a silver bullet, if you like, a very particular target or pathway to turn things on and off. And they've become widely used, for example, in the treatment of severe asthma, where they're very good at turning off the pathways that drive severe asthma. So in sarcoidosis, what we're talking here is about the drug infliximab that Rabina mentioned earlier, which is a class of drugs that blocks a chemical messenger called TNF, human necrosis factor, which we believe is deeply involved in the formation and maintenance of those granulomas that form the basis of the sarcoidosis lesion. And so if you give infliximab every few weeks, which is an antibody against TNF, that may be quite effective. But it has to be given by infusion, so it requires a hospital attendance. So that's a big disadvantage. It is also, because it affects the immune system, associated with a risk of infection. Occasionally, it can cause allergic reactions after the infusion, which you have to be careful for. And currently, again, the situation in England is that it's NHS England has said that we can use it in people who've got severe sarcoidosis that's already been treated with steroids and another drug like methotrexate, and it's not being controlled adequately despite both of those two treatments. And then you could add in something like infliximab. So I've used it a few times with a few patients, but not very widely or very extensively. And I think the requirement for a hospital visit each time for an infusion is one of the major downsides. What's your experience, Nick?
Yeah, so we don't use biologics very often at all because of the restrictions, and fortunately most patients don't need biologics, which is really because other treatments are very effective, and it's the other treatments that the question was also asking about, which is the immunosuppressive drugs. So it's so yeah, so these are mycophenolate, methotrexate, azathioprine, predominantly the three main immunosuppressive drugs. So I think that the issues are um, so unpleasantness, unpleasant symptoms, serious side effects, and then the long-term risks. So the unpleasant symptoms of all these drugs, to some extent varies between which drug you're using, but generally they're GI symptoms, reflux, tummy pain, constipation, sometimes diarrhea, headaches, fatigue. Those are symptoms that are common to lots of immunosuppressive, and that's really not specifically the immunosuppressive effect, but that's the drug effect, effectively, of taking some of these drugs. The more serious side effects, specifically for immunosuppressive drugs, are that by definition they suppress the immune system and therefore your ability to fight infections. They suppress the immune system sometimes, very rarely, so far that you have a low blood count, anemia, a low platelet count, leading to increased bleeding, and a low white cell count, leading to increased infection. So that's rare, but that's why we monitor um, your blood tests every few weeks and then months with these sorts of drugs. And then sometimes these drugs can cause kidney and liver problems depending on which drug you're taking. And again, we monitor kidney and liver function in time. So those are the kind of serious side effects. And some of the side effects, they're serious because sometimes the patient doesn't know they have these side effects unless the patient's being monitored. And then the long-term side effects, I mean, the immune system is obviously important for fighting infection, but it's also really important for fighting against cancers because abnormal cancers, abnormal cancer growth, your body's immune system um, has the ability to fight these cancer cells uh, in the body and destroy them. But immunosuppressive drugs can lead to increased risk of some cancers. It's not all cancers, and it's not sometimes what we think of the most serious cancers, but the cancers that they increase the risk of are skin cancers, um, and these aren't melanomas, these are the other cancers, basal cell carcinomas and other cancers. Sometimes lymphoma, which is a kind of a white blood cell cancer of lymph nodes, and very occasionally bladder cancer. But these are rare. Statistically, there's an increased risk, but the statistically increased risk is from a baseline of low risk to a slightly higher risk. So, and of course, these immunosuppressive drugs are being used for a reason. And the reason is to improve the quality of life and to mitigate to fight against the long-term damage that sarcoid induces if it's uncontrolled in a different organ. So obviously there's a balance, but patients should be aware there's a long-term risk. And long-term means 5, 10 years, I mean 10 years of immunosuppressive treatment. A year or two shouldn't increase these risks, but 10 years or more will have an increased risk. It's uncommon for patients to have this immunosuppressive treatment for that long, but it does occur, and I've seen patients that have azathioprine or mycophenolate or methotrexate for 10 years or more.
Okay. Let us move back to long-term steroid use just for a second, if I may. Osteoporosis is often linked to long-term steroid use. The question is asking, is the risk actually greater than the reward? Should bone density be tested? And then it's the question, whose job is it? Is it the sarcoidosis consultant's job to do that, or is it something that GPs should be doing?
I can start with that. So yes, we've touched on bone density and long-term steroids. It's an increased risk. The bones start thinning. I'm told within a few weeks, within a few days, actually, but it's definitely a few weeks of starting, obviously not thinning bones, but the metabolism changes within a few days, and your increased risk of bone thinning within the first few weeks. So it doesn't take a long time. Of course, the longer you're taking steroids and the higher dose, the more risk you are of bone thinning. Should bone density be measured? So our protocol in our hospital is to measure a bone density in a patient that you are planning long-term steroids on if they're over the age of 50 or maybe 55 and have other risk factors that would think of bone thinning, which is a strong family history or alcohol intake or liver disease or renal disease. So it should be done. The issue is practically, it takes quite a while. The waiting list for a bone density scan is quite long, and sometimes when I have to start steroids in a patient, I have to start them quite quickly. So I would book a bone density scan, but often I won't get the result or even the test done before I start the steroids. And the GP in Scotland or in our region, GPs can order bone density scans, but it may not be the case for every region.
Yeah, I agree with that, and it's we've already touched on bone protection, haven't we, with about vitamin D and bisphosphonate treatment. And I see that Martha in the chat has mentioned about zolendronic acid, which is an infusion of a bisphosphonate for bone protection. So again, it's something. It's very important issue, Greg, because thinning and weakening of the bones might not sound much, but it confers increased risk of fractures later on, and that can be really troublesome.
Okay, well, we talked a year or so ago about the research that was going into the sort of big hope, really, of steroid-sparing treatments and the alternatives that are coming down the line. How are those trials progressing? I hadn't heard a great deal in recent months. I know you're both involved in various research activities.
Shall I kick off, Nick, with this one, and then you can come in? Yeah, so it's absolutely fantastic that pharma companies are taking an interest in sarcoidosis, and it's really a new era of pharma companies running well-designed, proper clinical trials to look at new drugs for sarcoidosis. That's, it's absolutely fantastic. We've personally been involved in two of these recent multinational trials, and there are a few others going on as well. It was always going to be a learning curve because, as I think we've discussed in these four before, Graham, sarcoidosis is a condition that affects people in different ways. So working out what you're going to measure as an endpoint in a trial, that is, what are you going to measure to tell whether your new drug is working for sarcoidosis or not? That was a matter of much debate. And the two trials that we've been involved in, which were run by a company called aTyr and a company called Kinevant, both used steroid dose reduction and the ability to come off steroid treatment without any rescue treatment as their endpoints. And those endpoints were decided in negotiation with the regulators, who are the people who decide whether a drug would be given a license if shown to be effective. So what the regulator says, the FDA in the States in this case, is what everybody does. Now, unfortunately, neither of those trials met their primary endpoint. In other words, there was no major difference between those patients on drug treatment and those on placebo, dummy, in terms of the steroid reduction or ability to get off steroids without needing any more. aTyr's study, though, did show a number of signals suggesting that more patients on the drug treatment were able to get off steroids and feel better at the same time. So it may be that that's a better endpoint, but there was always going to be a learning about this. And one of the things with new trials in sarcoidosis is actually working out what is going to be the best thing to measure to determine whether the drug is working. So there's progress in that respect, and we're likely to have future trials. The other thing I would say is that I think, when I speak for my patients who were involved in the trials, it was a rewarding exercise for them, partly because they were very closely monitored as part of being in the trial, as well as them contributing to new research knowledge. So it is beneficial to be in a clinical trial. So something that people should consider in terms of future trials coming along. Nick.
Yeah, I'd agree with that, especially the endpoint of steroid reduction, which is a very difficult endpoint to have, and people and physicians prescribe steroids in sarcoidosis when the patient feels they are getting worse, and sometimes it's very hard to measure, exactly as you're saying. The other thing to say is that so we do have an alternative to steroids. We've had it for years, but it's only just been recently proven that it's a genuine alternative, which is a methotrexate, which we've already mentioned, that we used second line on top of steroids for many years. But recently, I don't know if you've already mentioned this in the first part of the conversation, or even you've had a talk on this, but there has been a study, a Dutch study, where they compared methotrexate with steroids, either or, so not both, but either or, in patients that have lung sarcoidosis, just lung sarcoidosis at presentation. So, and the motivation was that patients don't like taking steroids, quite rightly, for all the different reasons. So they randomized them to either methotrexate or steroids. And the bottom line is that they're both as effective for lung sarcoidosis if you measure the endpoint of forced vital capacity, which is the ability for you to breathe out as much air as you can after taking a deep breath in, basically a volume measurement of air. And if you use that measurement in patients with lung sarcoidosis, methotrexate is as effective at the end of the study, which I think was about 6 months, I think, as steroids. The methotrexate just took longer to improve the lung function. Steroids worked faster, but by the end of the study, both patient groups, the placebo arm, so the prednisolone arm or the methotrexate arm, achieved the same lung function. So the important thing about that is that these patients on the methotrexate arm were spared steroids, but both patient groups had adverse events or side effects, but they're different side effects. The steroid side effects are the steroid side effects, as we all know, which we described before: weight gain, insomnia, increased appetite. And the methotrexate side effects are nausea, fatigue, some abnormal liver function tests. But the amount of patients that had side effects were similar, but they're different side effects. So there is an alternative for patients, especially if they don't want to, or contraindicated for steroids, or relatively contraindicated with steroids, for using methotrexate. But it's a different set of side effects that they confer.
Thank you. Right, we are down to our last couple of minutes. So if I can just ask you a more general question, in fact, because last patient day we had Dr. Tarunya Aaron talking to us about her new multidisciplinary team approach, which is working, I think, particularly well in the West Midlands. And the question I asked, are similar things happening now elsewhere? Are they gaining momentum, and are they actually working?
Well, I'll answer that briefly. That we don't have. I don't have any experience of a multidisciplinary team. For years and years, I've tried to formulate these things. The bottom line is that you need a very motivated people with time in their diary to do that, and that's very difficult. And congratulations to anybody that does it, including Tarunya, that she's motivated and her colleagues are motivated to do it. I wish I could have that, but it's not feasible at the moment. Simon.
We run a little cardiac sarcoidosis MDT between the sarcoidosis clinicians and myself, and cardiologists and cardiac imaging people who do MRI and PET scanning, which are the usual imaging modalities in cardiac type. And now we don't have very many cases, and we don't run that meeting very often, but it's a good exercise, and just to share ideas and best practice. And cardiac sarcoidosis is a field that's in even more need of research and evidence than pulmonary sarcoidosis. But for other rarer manifestations of sarcoid, I think you already touched on this, Nick, like neurosarcoid, for example. And I'm sure you do the same, Nick. We basically convene a mini MDT where we may have a phone call or a Teams meeting with the neurologist or the neuroimaging people all together, and come to a consensus about the best way to go forward. So that works.
Okay, well, can I say thank you to both of you? That I think was very helpful. We've covered nearly all the questions that we had to cover. I've left you some soft thoughts another time. And we've also picked up on most of the questions that came in from people today. So thank you for your time. And I hope for those who are watching that we have answered your questions. Obviously, if we haven't, please reach out to us, email or our helpline, and we'll do what we can to help you.